Thank you for inviting me to consult on this topic. My name is Amanda Wolf. Today we are convening to review the risks and benefits of leading psychopharmacologic treatments for people with schizophrenia in recommending an applicable intervention. To substantiate the implications of treatment, we will first review the symptomology of schizophrenia and the major neurotransmitters inferred in schizophrenia. We will conclude with a recommendation for treatment, considering the potentiality of non-psychopharmacologic treatments. As this is a pre-recorded discussion, any questions or applicable feedback can be submitted directly to the discussion forum or my email, which will be provided at the presentation's conclusion. The DSM-5 classifies schizophrenia as a psychotic disorder, which affects the patient's mind, distorting their perception of reality. However, current research indicates schizophrenia is more closely related to neurocognitive disorders, with the onset of symptoms as early as childhood or early adolescence. The course of 4 neurodevelopmental stages is indicated by neurotransmitter interference and accompanied by specific symptoms, which could assist in clinical diagnoses and early interventions. As symptoms persist, psychosis becomes severe in most patients, negatively impacting neurocognitive, behavioral, social, occupational, and interpersonal/relational functioning. As we know, there is significant variability in the clinical presentation of symptoms for each patient, which can contribute to the potential efficacy of individualized treatment regimens. Symptoms of schizophrenia are divided into 2 major types, positive and negative. Positive symptoms include hallucinations, delusions, thought disorders, movement disorders, and bizarre behaviors. Negative symptoms include significant reductions in emotional expressions, speaking, anticipatory pleasure, and motivation. Cognitive impairment, especially memory deficits, impeding the patient's functionality, may also be symptomatic of schizophrenia. Therefore, to increase the strength and validity of treatment recommendations for schizophrenia, understanding the potential relationships between a patient's symptoms and the major neurotransmitters is necessary. Several neurotransmitters have been observed to contribute to the major symptoms of schizophrenia, including dopamine, serotonin, glutamate, and gamma-aminobutyric acid, also known as GABA. Dopamine is associated with functional movement, attention, learning, and emotional regulation. The dopamine hypothesis of schizophrenia suggests that increased dopaminergic transmission in the mesolimbic pathway of the brain mediates positive symptoms, while decreased dopaminergic transmission in the mesolimbic pathway imparts negative and cognitive symptoms. There is substantial evidence suggesting an interconnection between dopaminergic transmission and other neurotransmitters contributing to schizophrenic symptoms. Serotonin is associated with emotional regulation and general states of happiness. Dysfunctional serotonergic transmission in the prefrontal cortex, generally associated with serotonin syndrome, mediates the negative symptoms of schizophrenia. GABA controls cortical functions and anxiety. While the relationship between GABA and schizophrenia is not well known, it is hypothesized that GABA is beneficial in inhibiting dopaminergic transmission. Glutamate excites all neurotransmission and necessitates the synthesis of GABA, which is vital to the central nervous system. Glutamate also mediates memory, which is attributed to negative symptoms. As schizophrenia is a psychotic disorder, the first line of treatment is antipsychotics. Antipsychotic psychopharmacologic treatments are statistically significant in reducing mortality for patients with schizophrenia up to 50% compared to patients who do not use medications. Some of the first-generation antipsychotics, including chlorpromazine, fluphenazine, and haloperidol, are known to change mesolimbic dopaminergic transmissions, assisting in the management of positive and negative symptoms. However, first-generation antipsychotics do not always manage symptoms effectively, and the side effects are often intolerable to patients. Second-generation antipsychotics, including clozapine, risperidone, and aripiprazole, have a higher potency for blocking serotonin and dopamine receptors, reduced negative side effects, and increased patient tolerability. My recommendation for treatment, given the efficacy, tolerability, and potentiality to increase patient mortality in patients with psychotic symptoms, is aripiprazole. More specifically, studies have demonstrated that aripiprazole does not exacerbate cognitive impairments or cause weight gain, and it is available in a wide variety of formulations to suit the patient's needs. The FDA has warned that aripiprazole may trigger impulsivity and compulsive behaviors. Medication should be prescribed based on the patient's necessity and continued based on tolerability. Additionally, in alignment with the PORT treatment recommendations, I recommend conjunctive patient-centered psychosocial therapies to increase education, awareness, and support in facilitating optimal treatment outcomes. As we know, the complex neurochemistry of schizophrenia contributes to high variability in symptomology. Subsequently, not all possibilities have been exhausted when considering the onset of symptoms relevant to treatment recommendations. Other neurotransmitters and influential factors should be regarded as contributing to the onset of the disorder. Nonetheless, aripiprazole conjunctive with supportive therapies is conducive to reducing positive, negative, and cognitive symptoms of schizophrenia and potentially increasing the patient's quality of life and lifespan.